So years ago, the disease was called multiple myeloma because of multiple lytic lesions, and over the years we've tended to shorten that and just call it myeloma, partly in fun, but partly because, excuse me, it's true. I think it's time we start thinking of it again as multiple myeloma because there are so many different phenotypes or different types of myeloma. In particular, we know that there is a high risk pattern that affects about 20 to 25% of our patients, so that even though the other standard risk patients do particularly well, many of them living over 10 years, the high risk patients barely make it 2 years, and we more and more can identify who those patients are, either by doing FISH analysis on bone marrow or by doing gene expression profiling, but identifying them is becoming important because we may in fact treat them differently. We have some early evidence that maintenance therapy after an autologous stem cell transplant makes a difference, especially for these patients, and that using more than a single agent, for example, standard might be Revlimid, but using lenalidomide, bortezomib, dexamethasone for several years may in fact convert these high-risk patients to standard risk.